person, so I'm going to struggle with it. I can't speak out of the right side of my mouth, I think. My name is Mary Verdon, and when the Scholarship of Teaching group got together and was looking at some input from people who had previously attended Scholarship of Teaching sessions, the request was brought forward that we take a look at quality improvement, in particular quality improvement as it relates to faculty roles and what we teach our students. And my name was brought up as someone who might be able to help with this, and as the group came to me, I absolutely felt like I needed a whole lot of other people in my corner. Quality improvement is not something that we will be able to talk about in 1 hour or in the 4 hours that we've allocated in this series over the course of a few months. And we can't expect anybody with that amount of information and education about quality improvement to be proficient. When you look at the information that's out there in peer-reviewed literature, in the scientific literature, about how much education it takes to educate faculty members to be able to feel like they can actually participate in quality improvement activities to the fullest extent and have a depth of knowledge that enables them to feel like they are expert. We're talking tens of hours, if not several hundred hours. So this is designed, this next 4 sessions is designed to, first of all, bring before our colleagues a group of us who feel passionately about quality improvement, have some exposure and some experience to quality improvement, either in past roles or current roles. And it's also designed to trigger a dialogue among the group. And today is not going to be so much a dialogue because we felt like we needed to have a foundation where everybody was kind of on the same field. So what we're going to do today is an introduction to quality improvement. Many of you may feel this is familiar territory, but we felt like we needed to get all of us kind of to the same point before we could begin then to talk about teaching quality improvement and how quality improvement translates into the real world of health professions. So with that as an introduction, today we're going to be talking about, and what we would hope to accomplish through the course of the hour, is really have you have a feel for the connection between professional knowledge, whether you're a physician educator, a nurse educator, or in the School of Health Professions, and the knowledge of improvement theory that's required for practice-based improvements. So you kind of have to have a conjoining of 2 types of knowledge to be able to do this work. We want to also serve over the course of the next 4 sessions as a model for you of talking not only about talking why it needs to be interprofessional, but hopefully demonstrating the importance of interprofessional dialogue and interprofessional approach to education and performance and practice-based improvement. And finally, we want to introduce you to the fundamentals of the IHI model for improvement. So to start with, what's quality and what's quality improvement? And what kind of definitions are we using? In the very beginning, in the early 1900s, Frederick Taylor was kind of the father of scientific management in the United States. He gosh, I've lost my word. He put out there 4 scientific principles, 4 principles of scientific management that he really hammered home in everything that he did. He replaced what used to be in the arts and crafts era kind of rule of thumb measures for how you did things with a scientific study of the tasks involved in getting something accomplished in the field of manufacturing. He said that we ought to scientifically select and train and develop each employee rather than expecting the employee themselves to do on-the-job training and to kind of educate themselves. He believed that we needed to provide detailed instruction and supervision of each worker in the performance of that worker's task. And finally, he said, you know, what you need to do is you need to divide the work nearly equally between managers and workers. And the managers were the people who were well educated and the workers were the people who did as they were told, and they were kind of cogs in the machine. So that was where Taylor was coming from, and it worked really well in manufacturing, but it doesn't work so well in our environment. It really fails in the face of increasing complexity. And then shortly after Taylor, along came W. Edwards Deming, and you may be familiar with Deming as being the developer of what we now know as the Plan, Do, Study Act, or the Plan, Do, Check Act cycle, which is named, which Deming used, and he is most commonly associated with that. He worked particularly in Japan post-World War II, and he's really credited with having had the most influence on Japanese manufacturing and technology of anyone who is not of Japanese extraction. He made a significant contribution to Japan's manufacturing arena and was only really just beginning to be known in the United States when he died in the early 90s. I love this quote. Medicine used to be simple, ineffective, and relatively safe. And boy, we know that is not where we are anymore. So in the early 2000s, following on the heels of the I.O.N. report to Err is Human, came a report out called Crossing the Quality Chasm. And the importance of this report was that it really identified between where we are currently and where we would like to be with healthcare, or where we need to be with healthcare. There's not only a gap, but it's a huge gaping chasm. And this I.O.M. report, Crossing the Quality Chasm, identified about 5 or 6 areas or aims in their definition of what is quality. Quality is care that's safe, care that's effective, care that's patient-centered, that is timely, efficient, and equitable. In other words, it doesn't vary in quality because of who the patient is in terms of gender, ethnicity, geographic location, etc. And out of the Crossing the Quality Chasm report came the recommendation that we then have another national summit. And the summit was held in 2002, and out of that summit came a 2003 report called Health Professions Education, A Bridge to Quality. And in the sign-up for this session, for this group of sessions, you'll see kind of a little administrative summary of that. But basically, this report said we've got to integrate a core set of competencies into health professions education. It has got to be patient-centered, interdisciplinary, evidence-based. We have to know more about quality improvement, and our students have to know more about quality improvement, and it needs to be supported by informatics. The goal of this report and the goal of where this report was headed with these recommendations is that an outcome-based education system needs to exist that better prepares clinicians to meet both the needs of patients and the requirements of the changing health system. Now that's pretty complex. So what is quality? You couldn't give me a 30-second elevator speech based on this probably about what's quality. So probably a more useful definition is quality is the degree to which we meet or exceed customer definitions. And the goal is we need to meet or exceed customer expectations 100% of the time.
Thank you, Mary. And Mary Gambino, thank you for that introduction. I kind of like to hear myself introduced. It makes me feel kind of important. And then a couple weeks ago, my oldest granddaughter, who's 8, saw me on television. She said, Mimi, I saw you on TV. And I said, I know, I'm kind of a big deal. And she said, no, actually, you're not. They didn't even say your name. So I guess it really matters on who the audience is as to whether you're really a big deal or not. But my part of this is to talk about that real-time, real-life application. And so when we talk about quality, it makes sense to talk about doing the right thing and doing it 100% of the time and making sure we follow a process and a system. But what does that mean for our customers? And in healthcare, that customer is our patient. Probably every one of us in this room have been a patient or have a family friend or friend who have been a patient. And what do those customers, our patients, what do they want and what do they expect? Do they expect some things that provide basic quality to them, right? Like to come into a clean environment. Have you ever been to a facility to receive health care that wasn't clean, that had dirt on the floor or trash piled up? You immediately get a sense that things may not be quite right. They expect the processes of admission and discharge and flow to be smooth. They expect people to be nice. Sometimes that's hard, and sometimes we don't always reach that. They expect the level of technology and competency to be utilized. They expect the physicians to be specialists, to be experts in what they do in both knowledge and in behavior. They also expect to have a good medical record so that there's good communication across the different systems and specialists that they need to see. And that last one, taste and temperature of food, you might be thinking, really? But yeah, really, that's a big deal. Food is a big deal. And coming from the chubby girl, I can tell you food is definitely a big deal. People like to have those basic comforts, though, of shelter and food and water. And so having that ability is really important. And then pricing is becoming more and more of a big deal for our patients. So our customers, our patients, have some basic expectations. They have the right to come to the hospital and not leave dead because they acquired a hospital-acquired infection or a complication, or leave sicker than when they started because of a hospital-acquired condition or infection or some type of a complication or risk. They have that right. They have the right to have a short stay, to not have to be here longer than they need to be, to not have to be away from their family, away from their community, away from their job because we couldn't get our act together to get them through the system. They really do have the right to have the best care ever. We also have other customers that kind of dictate to us what we need to do for our patients, not just because it's the right thing to do, but because they say we have to do it. And that's where the regulatory environment really comes into play. You know, we have the government payers, Medicare and Medicaid, that tell us what they will and will not pay for services and how we need to do it. Third-party payers follow those suits very, very quickly. And so we really get into that realm of having to meet the regulatory requirements and balance that with the best needs and indications for our patients. What about the media? How big a part does the media play in a customer's perception of health care? So I used to work for Truman Medical Center a long time ago in their trauma world, but this was a long time ago. Many of you may not remember. But on the front page of the Kansas City Star was a picture of our one and only neurosurgeon on a jet plane, and the caption read, "Only neurosurgeon flies to India." And so the article itself was about the lack of neurosurgery services and the lack of services for the population, and it was meant to be good, but that title and picture made it seem like that particular hospital didn't have what they needed to take care of those people, and so that was interpreted very differently, and the backlash from that was very different, and so we see a lot of that every day. So how many of you have heard of this concept of never events? So these are some of those regulatory compliance things that we talk about. And CMS has come up with this very long list, and it actually gets longer and longer every year, of all of these never events. And what they have attempted to say related to these never events is that these should never happen. These are conditions, hospital-acquired pressure ulcers, venous thromboembolism, respiratory failure. These are conditions that should never happen. And they may be right to a certain extent. What it also translates to is that you're never going to get paid for them. And so it really does hit you kind of in that cost pocket. And if y'all can see this, these are just some examples. Now, they're several years old from when these numbers came about. But if you look at the condition itself, so a pressure ulcer, the number of cases that CMS identified, and then the dollars per stay that hospital lost reimbursement, $43,000 per stay. So they pay for the initial DRG, but not for the additional complication that's associated with it. So the hospital then incurs all of the cost for all of these hospital-acquired conditions. Sometimes you can do everything right, and still your patient will have a complication that you will not be reimbursed for. And so we just have to be very careful. What about medical errors? How many of you have personally experienced, had a loved one who experienced or committed a medical error? I'd say if you're not raising your hand, you're probably not being 100% truthful, because it's ubiquitous. Everyone has experienced it in some way, shape, or form. I've made a terrible error in my career in nursing. I gave Pavulon, which is a paralytic, to a non-intubated patient who was very quickly intubated. And that worked out just fine. But it was a major error, and my patient could have died, and we all do this. But medical errors are very, very expensive as well, and patients expect to not be on the receiving end of those medical errors. Is this you or me? Oh, me too. Okay. So when we talk about the context of performance improvement, quality assurance, within the realm of healthcare, it gets very confusing because people use this terminology kind of interchangeably. And in actuality, they all mean kind of different things and have different concepts to them. The ones that we're going to focus on really are, what does it mean for patient safety? What is this culture of safety, and how does it impact the work that we do? How do you use the quality assurance, like process checklist, to put into an improvement model? And really what it all kind of ends in is this new catchphrase in healthcare, and that's PIPS, Performance Improvement in Patient Safety. And I like this phrase. It actually came from the American College of Surgeons through their trauma verification about 6 years ago. But I really, really like this phrase because it brings in the whole reason of why we're here and why we're doing what we're doing, which is to provide the very best care for our patient population. Oh my gosh, okay. So when we talk about performance improvement in and of itself, it's different than quality assurance. You know, quality assurance is taking that checklist and checking the box and making sure that you've got everything right. And oftentimes when our new folks come to us, the new nurses or new staff, they use the words interchangeably and they don't really understand. The greatest example I can give is when you check your code cart every day to make sure your defibrillator works and to make sure you have the right drugs on and you have the ambu bag, that checklist, that's quality assurance, making sure that you have what you need to do the job you need to do. Performance improvement then would be taking that process that's not working or a procedure that's not functional, you're not getting the outcome that you want, and putting those changes in place to increase the output, to improve the efficiency, or to increase the effectiveness of what that has. So that takes a whole different look and requires really a different team and a different mindset to do performance improvement. Now, Dr. Williamson?
Actually, I was supposed to do those. I just wanted to see if she'd keep going. We're going to be passing off back and forth a little bit here. So what we wanted to do, though, is kind of get down and put a little base coat and really talk about the nuts and bolts of, okay, so you see something that you want to improve. How do you set up a project that might do that? And so we're going to talk through that a little bit here. I will start by saying I think the best projects come from your environment, from looking around and going, what isn't quite working? Maybe that's anything from how we onboard new nursing students to how someone gets admitted or discharged from the ICU to circumcision care for newborns in the newborn nursery. But looking around saying, this isn't quite working the way I'd like it. How can I improve upon that? And a lot of times I think people get scared because they think of quality improvement has to be this big, grand thing. And sometimes it is. Liz and I are part of a VTE team that is a very large project that is probably 20 to 30 people that meet twice a week and have for 2 years. And that's a big project. But this can also be 2 or 3 of you working together to really impact a change in a problem that you see in your everyday workflow. So we're just going to talk a little bit through, and we'll talk about each of these in more detail. But really, you can kind of break down the process into 2 parts. The first is defining what you want to do, and we do that through use of an aim statement. And that's just saying, okay, this is what I'm going to do. And the more specific it is, the better. If you start off and say, I'm just going to make care better, I'm going to improve quality, you're probably not going to get very far. But if you start off with a very specific aim, that's likely to be more successful. And then we're going to talk in detail about the PDSA or PDCA. They're used interchangeably, about what that entails as we go through here. So how do we develop an aim statement? This may seem like a trivial thing, but if you don't really have a roadmap of where you're trying to go, then you'll never get there. And the first thing is really to state the aim clearly. You want to use very specific numerical goals. You want to very specifically define the population or subpopulation you're going to work with, and then state the time frame. So In more detail, this is just a little mnemonic that a aim statement that is a good aim statement should be very specific, it should be measurable, actionable, realistic, and timely. So for us to say that we will eliminate central line associated bloodstream infections in the next 10 days at the University of Kansas, it's really none of those things, but to say that we want to decrease the number of VTEs over the next year by 25% in surgical patients would meet all of those sorts of criteria. So another aim statement, for example, by the end of 2011, our health center will initiate the use of impanelment registries and care management processes. We'll do it by hitting these goals, 90% of patients, 75. So it's specific, it tells you the population, there are numbers, and it gives you a time frame to work in. And any, particularly the larger project, the more important it is that you do this at the beginning. Now, the Institute for Healthcare Improvement has really provided a model. There are lots of different ways to do quality improvement, but they've provided, I think, a very simple and a very applicable model that works well for small projects, large projects, and everything in between. But the questions that you have to start out at the beginning is these three questions. What are we trying to accomplish? What do we want? What are we trying to do here? How will we know that a change is an improvement? Essentially, what are we going to measure? And then what change can we make that will result in improvement? So what can we do that may fix or impact the problem?
Yeah, so we wanted to just share with you guys the PDSA cycle. And if you study for the Certified Professional in Healthcare Quality exam, which I am currently doing, it may be the hardest test I've ever taken in my entire life, but they give you several chapters on different models and methodology that you can utilize. And some of them have 15, 16, 20 plus steps, and they're complicated, and they're redundant, and they're kind of boring. So we looked at what is really the best model for us. What is something that is simple, that's easy to use, people can remember, and can be effective, that you can put into place without having to have specialized training. And the PDSA model is really that, and it's very, very simple. It's very simple, 4-step, it's rapid change, and it happens can happen very, very quickly, and like I said, without a lot of training. The first step is the plan, and that plan is really important so that you sit back and you really define what it is that you want to study, and what it is that you need to fix, and what it is that you need to have an outcome around. The data here is very, very, very important because data is power. Data is what gives you the clout to get the decisions made that you need to make. It also helps to kind of alleviate any of those naysayers, those folks that say, well, that's not really, my team doesn't suffer from that, or my patient population is special and they don't have those issues, or that doesn't happen in my world. That data really gives you that energy to do that. There's a lot of different ways that you can kind of identify the real issues around the problem, and I don't think in this particular class we're going to get into the details. I think we're going to do that in level 3 of the different tools that you need. But you can do some mapping, you can do some charting and some different things to really identify what the root of that problem is, so that you can do identify what the plan is.
Yeah, and along those lines, like Liz was saying, first, we're just going to stand here and hand back and forth. We've practiced this extensively, can you tell? The first thing we do is show people the data. And as you take data and present it to any given group, almost universally, what is the response? What would you say? The first response is, that that ain't right. And the second response is, particularly if you show it to an ICU doctor, my patients are sicker than that. I take care of sicker patients. I mean, there's something about my population that makes me special that doesn't apply. And so, and sometimes that's right, and sometimes that's absolutely the right thing. We've seen that before here at this institution, where people brought in, showed data. We said, no, that isn't quite right, and in fact, it wasn't quite right. And so you have to make sure you've got the right data to begin with. So it is a valuable process, but more often than not, it is right. The next thing is putting together a team. I already said it can be a very small team, or it can be a very large team. And it really should be right-sized to the task at hand. But the key principles is having the right people on the team. Now, one of the things and it really needs to be an up-down approach. And by that I mean you got to have people who really know what's going on in the processes, and you need people who can authorize change. So to that end, one of the things that Dr. Deming really focused on was this thing called frontline process knowledge. And basically it says that healthcare is complex, and each institution has this fundamental knowledge, and that fundamental knowledge is stored in the frontline workers. So if you want to know how a patient gets admitted from the ER, the last person you want to ask is me, because I'm not going to be the one to tell you. Actually, the last person you probably want to ask is Dr. Norman, but the next to last person you want to ask is me. And the person that really then, if you were working on a process to improve, say, ER admissions, should involve the residents, the fellows, the bedside nurses, et cetera. So you need frontline people involved for sure on the team, and we certainly have had that in the teams that we've put together. But at the same time, if a team works for a year trying to come together with a plan and takes this whole plan a year later to someone to implement, and the executive says, well, no, we're not going to do that, then you've wasted a lot of time. So you need someone involved the entire time who is authorized to facilitate change. The other thing we would stress is, when I don't think we can stress enough, is the value of an interprofessional team. Whether we call this interprofessional or transoccupational or multidisciplinary, but that we have members. Transoccupational is not catching on, I don't think, but I keep trying.
You didn't even get a giggle.
I didn't even get a giggle. But it's really, the goal is to have, to erase the silos and have nurses, physicians, pharmacy all working together, because each person has a piece of that, of the process that they can help change. Liz mentioned briefly there are some tools that we can use. It's beyond the scope of what we can talk about today, but just to let you know, there are tools out there to help that diagnostic process as you try to figure out, okay, what's causing the problem, and so then we can work on something to fix it. The circle actually missed. I think that it really should have been around the Pareto charts. All of these work in the right situation. One of the things that we found most useful are these things called Pareto charts. Pareto was an Italian guy who said, he was the one who said 20% of the people will cause 80% of the problems, or 20% of the people make 80% of the money. And so it's a way of focusing, because we all have limited time and energy and resources, so that we can focus on where the real problem is. So, excuse me. For example, this is one example of a Pareto, looking at what we did when we were trying to figure out what was causing problems with our elevated VTE rates. And we had some very different assumptions going on, but when we reviewed charts, looked at the problems, we found that really the majority of VTEs we were seeing were related to PIC-associated occlusions, and that some of the other things we thought might be going on were very rare indeed. So this is a way to focus your efforts, because if we were to spend time really on delay in prophylaxis or interruption of prophylaxis, we would be missing the really big bang for the buck.
So I said earlier that, data is power, but it's not enough just to have the data and show people the data. You have to have some action associated with it, and you need to basically just do the work. And in doing the work, you put that solution into place. It's really important that you use that data to really identify what the right solution is. And Dr. Johnson, I'm going to use your maternal child quality meeting yesterday as we started talking about an issue that team was having. They started hollering out kind of all these different reasons as to why this was happening, and they were going to do X, and they were going to do Y, and they were going to do Z to kind of put the Band-Aid on all those different issues. And I said, stop, just a moment. Do you really know that is what the cause is? Because does anyone have energy or time to spend putting an effort into place that really isn't addressing the issue at hand? And so you really do need to stop, look at that data so that you put your targeted interventions to the right thing. And the other thing that's really important here is all about change theory. And change theory is something that we don't get a lot of training on in healthcare, but it is imperative. It is so critically important that communication is at the very, very foundation of that, because people have to know and understand the work that's being done, why it's being done, how it's going to implement them, what their expectations and roles are in that particular change. And then you have to continue to evaluate that and show people those outcomes and the impact of it. So you can't really do performance improvement or quality improvement without pulling change theory into that and making sure that you focus on how that change works.
As we talk about this, it seems like a good time to very briefly take a sidebar and talk about as we measure things, and as we look at what we're going to impact, you can do your interventions and you can either measure process measures or clinical outcomes, meaning you can either look at the number of catheter-associated UTIs as a clinical outcome, or you can look at the number of patients who had their Foley out on day 2 as a process measure. The reason we talk about this, it's much easier and much quicker sometimes to measure process measures, but that assumes that the two are very closely tied, so that if you're assuming that if you're measuring one thing, because it's easier, that it's tied to the clinical outcome that you're assuming in it. And that can be a misguided association at times, so that they may be not truly causal. So we have to be careful, and it's just a brief caution that we should, whenever possible, measure the outcome measures and not just the process measures.
The next step is the S, the study, and that is to be sure that the intervention that you did actually ended up in the outcome that you expected it to do. And so you have to continue to evaluate. And often where we fall short is that we put an intervention or a plan into place and then we don't come back around to make sure that it actually worked, that actually did what we intended it to do, and it was sustained. And so in this study, which is very in this particular model of Plan, Do, Study, Act, which is very fluid, if you then start to look at that data again and it didn't work, you go back to P and you reevaluate and you put a new plan into place and a new do into place, and you just begin again. And what I like about this too in the IHI model specifically is that they recommend very small tests of change. So you don't put the action into place and then wait 3, 4, 5, 6 months to evaluate, to study it, to see if it worked. You do it, you put it in place for a shift and see if that worked, for a day, for an hour, for a weekend, and see if it had the impact that you wanted to. And you allow those small failures so that failing forward is okay. It gives you the information that you need to evaluate that next step. So in that next plan, you may get it a little bit more right. So you don't go for perfection right out of the gate, but just that continuous type of a cycle. And there's a little picture here shortly that will show this to you. The act is very important too, because once you figure out what the fix is, you have to hardwire it. Otherwise, you cannot sustain the impact of what you need to do. And that sustainability is something that is very, very, very hard to control, very hard to put into place. So what do you need to do to adopt the solution? How do you make sure that that improvement will continue? And there's a lot of different ways to do that. In healthcare, we use policies and procedures and guidelines and practice management guidelines and protocols and order sets and things that are automatic, so that we take maybe some of the thinking out of it, kind of like automatic seat belts in your car that will continuously ding at you until you put it on. You just don't have any choice but to do that. You can put some of those places or some of those interventions into place, but implementing those solutions for sustainability is critical. And then periodically you have to come back around and check and make sure that they're still working, because systems change and your particular solution may not be what you needed to be. And this is the slide I was talking about as far as the repeated use of the cycle, and that it's very fluid and very small tests of change, and it just kind of keeps moving until you get the results that you're really trying to get.
The other thing I would say about the PDSA or the PDCA cycle is it takes a bit of philosophical shift from how we're often trained in med school or nursing school or allied health school, in that we hear espoused and has definite roles, the benefits of evidence-based medicine. And so we all are waiting for, before we do something, we want a 64-center, multi-center, multinational, randomized, placebo-controlled trial that costs $10 million, and then will be proven negative in the next study, that's done as a follow-up. And so that this is a very practical, real-world way to make change, see if it works, and can accomplish often even more than the large evidence-based trials. So this is basically just a little quick summary of what we've talked about, saying that these two things we've talked about, the IHA model for improvement and the PDSA or PDCA Act, are really they're complementary. They work together. You use the model to kind of ask the questions and then use the PDSA cycle to implement your solutions. All right, a couple other things as we move forward here. What about cost? Doesn't doing quality improvement cost money? Well, I suppose it does in some ways, certainly manpower hours and depending on the size of the project. But everyone who's ever studied this shows quality and cost are the flip side. So as your quality goes up, your costs go down. As your costs go down, or sorry, as your quality goes down, your costs go up. And it's just they're inextricable. Is that a word? Did I make that up?
You're making things.
All right, they're related, and that it's important that quality and cost are very closely tied. This is not, well, it's about ready to be tornado season, so it seemed appropriate. I'm a big fan of despair.com. I have a little bit of a warped sense of humor, and if you have a warped sense of humor, definitely spend time. Despair.com. But this says, when the winds of change blow hard enough, the most trivial things can turn into deadly projectiles. And this is really a reminder for us to talk about balance measures, or what we might call collateral damage. You might think the things that you're implementing, and they're obviously intended to do good, but we also have to be careful of unintended consequences. For example, as we are with the VTE initiative trying to get more and more people on appropriate pharmacologic prophylaxis, what might our balance measures be, or the unintended consequences? Well, postoperative hematomas, for one thing. As we tried to reduce our use of PICC lines and increase our use of central lines, we have to be careful that the risk of iatrogenic pneumothoraces doesn't go up. So we have to be careful where we optimize one thing that it's not, and so it's important to anticipate those things and measure them as you go forward, so that you don't stand up and say, hey, look what we did, and someone else say, well, but look what else you did, and there were some unintended consequences. Some of the potential barriers as you do a quality improvement project that we've certainly seen examples of as we've done the things that we've done. Certainly if there are competing agendas, if there are people in the room who have different goals, either personally or for their divisions or departments, that can be quite challenging. One of the objectives talked about really that interaction between professional knowledge and improvement knowledge. So if you have a bunch of people who really know the professional piece of things, they know medicine, they know nursing, but they don't have the improvement piece, or if you have just improvement methodology but don't know about the medicine, that's not going to fly. And so you really have to have both and have those well integrated. Again, I can't stress enough, we beat this to death, I know, but the need for frontline personnel, we'll just keep saying it over and over. If you go into a project, or at least stay in a project with predetermined outcomes, then you're going to steer your project off course. We, I think it's fair, I'll go ahead and talk about, when we did our VTE project, when we started off, it's like, if we could only get the darn orthopods to start prophylaxing better, particularly with the spine surgeries. Guess who doesn't like to blame orthopods for things? And sure enough, we did the Pareto, and oh, by the way, these were all internal medicine. These were pulmonary critical care. It was my team, mostly Dr. Sharp. But it wasn't the orthopods. And oh, by the way, it had nothing really to do with prophylaxis. The majority of these related, not all, but a lot of these related to PICCs. So using tools to make sure that you don't get stuck in those predetermined outcomes. And then the other real important thing is you got to have folks who are accountable, and let's kind of talk a little bit about that.
Yeah, and so, yeah, I'm going to get a little lightning. No, so that concept of accountability, we're really talking about that culture of safety, or in some places call it the just culture. And this is basically just creating an environment where it's safe to talk about the failures, where it's safe to talk about the errors, where it's safe for me to say, you didn't wash your hands, I need you to go back out and wash your hands before you come in and talk to my patient, even though you're a physician and I'm a nurse. That's really what that culture of safety is about. It's about putting those policies and procedures into place, giving people the resources, and making sure that they know that they can say and do what they need to do to assure that safe environment or that safe outcome for the patient without retribution. We use this acronym in the hospital, which I think is great, and we ask people to take action, and that is to be accountable, to communicate with respect, to focus on teamwork so that we're always improving the system, that communication needs to be open and transparent, and then really focus on those near-miss event reportings, because talking about the almost happened is sometimes more important than what those things that actually did happen. The impact of a culture on safety is really huge. If you think about this is all about the work that we do and the patients being at the center and core. So we put these safety requirements into place. And those in and of itself aren't enough. You have to have a culture then that supports that so that those safety requirements are followed and you get that kind of safety culture. If you have folks who just blatantly refuse to participate, do you have rule breakers? You have people you work with that never, they're all perfect angels. Yeah, there are some people who just refuse to do what they know needs to be done. For whatever reason, they refuse to participate. And that complicates then, or doesn't allow you to have that safety culture. And then you have the culture itself that gets impaired when the norms start to shift, when the culture becomes one that those unwritten rules kind of take precedence. So when you say, oh, yeah, I know Dr. Norman didn't wash his hands, but that's just Lee. It's okay. Well, it's not okay. It's never okay, but we allow that to happen. And I just threw you under the bus. I know. But we do allow that to happen, and you probably hear that at some point every single day. Well, yeah, that's not actually the policy is actually X, but in reality, in practice, we do Y. And so those are the things that don't allow that kind of just culture or culture of safety to be created and to really be implemented. We have to hold people accountable for their behaviors, and oftentimes people think in a just culture that accountability goes by the wayside because people are safe to report those errors, and that's really not the case at all. If someone has a human error that is outside of them refusing to participate or having reckless behavior or at-risk behavior, then there is accountability through counseling. If it's reckless behavior where they're just kind of pushing the envelope on what the rules are, the recommendation is some coaching. But for those people who just have total at-risk behavior where they just intentionally refuse to follow the rules and do what they know is right, there does need to be punitive action associated with that. And so that's really what needs to happen in a true just culture. To make sure that folks stay accountable. You know, errors are inevitable. We know that human actions lead to errors every single solitary day, and we see that in our medical error rates for our patients in the hospital. And what we have to do is really try to eliminate all the factors that support that. And you can't do good quality improvement, performance improvement, if you don't have a culture of safety, because people won't talk about what's not working and what's not right and what, yeah, that's what the policy says, but that's not what we do. They won't do that, so they have to have that ability to have that just culture. You guys see that? Those are dark thunderclouds. So what is the perfect storm? Distractions, apathy, and disruptive behavior. All of that leads to this perfect storm that impacts our patients and leads to the things that we absolutely don't want to have happen, the hospital-acquired infections, the pressure ulcers, the medication errors, the mislabeled specimens. That's not why we're here or what we're intended to do. Remember, we talked about the cost of those never events earlier, and this is a direct consequence of that. So it's really about not being silent and having that ability to speak safely in that environment so that your process improvement work that you're doing is effective and can have the best outcomes that you want it to have.
So really our last slide here, and then we'll open up to Mary to come back up to facilitate some discussion and ask Dr. Norman to join us if there are questions. We have about 10 minutes for questions. But I think one of the toughest things, everything we've talked about has its challenges, but one of the toughest things in quality improvement is holding the gains, sustainability. So it's really easy to get excited about it. Well, if you're quality improvement geeks like we are, it's really easy to get excited about quality improvement. You're getting folks together, you're going to solve a problem, you solved a problem, look what you did. But trying to sustain that over time, 6 months, a year, 5 years. And so you have to periodically go back and look at what you've done, make sure that you haven't lost those gains. But you have to hardwire the processes, and that really sustainability becomes one of the biggest challenges that we face. So with that, I'll turn it over to Mary, and we'd certainly open it up to you all if there are questions as well.
Okay. Why don't we all come down front and take a look, and we may cast a shadow here, but here are some questions just to start the discussion this afternoon. Okay, while we don't trip over the cords and so forth. First question is, for you as a faculty member, how can I integrate anything related to what I've heard into the topics that I teach? As I plan syllabus revisions for next year, what can I do to integrate this stuff? Another question might be, what about IHI? How can I use that when developing or revising curricula? How can I create learning opportunities for students? How does the culture of safety influence practice and quality improvement? And I would add to that a question for you. How does the culture of safety influence what happens in the classroom? So with those as basic questions, we'll open it up for discussion, either about these things or about anything else that's been triggered this afternoon as you're thinking about the presentation.
Particularly for Dr. Norman. I would really
Yes.
encourage
Yes.
thoughtful, difficult questions for Dr. Norman.
You get the feeling they've done that tag team more than a few times? I call them either Lynn or Tiz.
Lim or Tiz. Lee, do you have anything that you'd like to add? We're limited on our length here.
There's a quality improvement project to be had here in terms of facilitation.
Now we just have to get close. A couple things. One is that Liz commented about hand washing. And, you know, it's interesting that we are so much a product of our environment. And I remember there were a few events in my own professional career, I guess you might say. One was, I remember in 1978, I was at John Peter Smith Hospital in Fort Worth doing a pediatric rotation. And this relates to the culture of safety. I was doing a pediatric rotation, and I knew that I had a pediatric patient down on one unit that had Haemophilus aegypti conjunctivitis, which is kind of an unusual bug, although not necessarily in that age group. And then I had another patient up in the newborn intensive care unit where I took call at night also. And I was the only link that had this. The one up in the newborn nursery, or the newborn intensive care unit, also had this Haemophilus aegypti conjunctivitis. And I knew I was the only, I did my epidemiologic work, and I knew that I was the only link between those two babies. There was no staff, no parents, no family, nothing. But at that time, do you think I took hand washing seriously then, or I should say ever since then. I must not have that day. But I remember thinking, did I fess that up to anybody? And the answer was no way. The culture of safety wasn't there. I thought I'd get hung, as a brand new resident, I thought he was going to get hung out to dry. And we still have a long ways to go. I was going to comment on, now that you know. Chet.
What's a recent example that you might share about the culture of safety where some nurse or physician really took a risk? Not just saying, would you please watch me?
The question is what's a recent example? I can say last week I met with a fairly large group of 40 operating room nurses and scrub techs. And there's a practice that has been used in the distant past of doing surgery on people's brains and using small wisps of cotton to mop up ooze there. But it's known that those cotton fragments stay on the surface of the brain and serve as nidus of infection. There was a performance improvement process that was undertaken that showed that was not standard of care and that it led to problems. That was a couple years ago. And this is holding the gains, as Tim mentioned. But one of the things that has come up is that they don't use cotton anymore, but there's an instance of a physician that will cut into a telfa pad, break it apart, and get that fuzz that's inside there, and because for the same reason. So it's like, geez, I thought we fought that battle again. But the good news is that there was a scrub tech that brought it up, said something to the doctor, didn't get a satisfactory thank you from the doctor who was doing this, and then felt comfortable enough escalating that and I think we will probably beat that into submission again for now, hopefully for good. But that would have not happened in a different environment.
I think another really good real-time example that we do every day and would be a reference that I would recommend that you use for your students is A.C.T.I.O.N's checklist manifesto. So that ability to use those checklists every day so that anyone on that interprofessional team, be it the therapist, the nurse, the physician, the resident, who can say, wait, we haven't addressed nutrition for this patient, or wait, this patient doesn't have a discharge plan. So that concept of the checklist kind of empowers people to be able to speak to things that you know in that kind of quality assurance concept need to be addressed. And that's something we've tried to implement pretty much in every area.
As probably many of you know, the airline industry is light years ahead of us, or has been. They, years ago, adopted essentially the same sort of thing. They called it different things, where they've empowered people to speak up for safety in the cockpit. And once they did that, when people felt empowered, they stopped flying, for the most part, flying planes into mountains and stuff, just because someone was afraid to say, hey, oh, there's a mountain. So we've got a long way to come. There's a great book, if you the checklist obviously is a great book, manifesto, but Why Hospitals Fly, or Why Hospitals Should Fly by John Nance, and it really paints a picture of what a utopian hospital could be like with that sort of culture of safety.
One other book that I would recommend too, as you're building this, I can't remember the author, I'll find it for you, but it's The 5 Dysfunctions of a Team, and it's a little itty bitty tiny, say it again, Lencioni. Yeah, it is excellent when you're trying to get that team together to get everyone on the same page to move forward for a common goal. It's very good.
We cover 4 of them between us. So.
Yeah, for the dysfunctions.
For the dysfunction.
Okay, what other questions or comments do you have at this point in time? Yes, absolutely. Let me attack that one just for a minute. The question basically is, at what point in time do our students, and I would broaden it from medical students and residents to all students, at what point in time do our students begin to bump into this in anything more than just a passing, kind of a glancing way? As having been a quality improvement professional for over 20 years, I was naively excited when I was in my mid-30s about the fact that, you know, by the time I hit 60, people are going to really know this, and the educational system is going to have caught up with where we are in the hospital and what we're learning and what Deming is teaching and what Duran is teaching and so forth, and I thought we would truly be here. And I was really very, very surprised. Ed Ellerbeck and Emron Rolfe, when he was here, and I did nearly 10 years ago now, did a series of resident education modules about using clinical data to think about quality improvement. And we had some good clinical data. We started out with a pre and post test, and we asked the residents, what kind of exposure have you ever had in your medical school education, in your residency program education? Basically, they said nothing. And this was a group of about 36 residents. So they basically said nothing. We've had none of this. And then we went on to ask them further down the questionnaire, how comfortable and confident are you that you can make improvements when you get out and establish your own practice? How do you think you can do this stuff? And it was almost a reverse. Almost 100% of them said, I'm very confident I can do this, which really showed me that there is a real lack of knowledge here of what it takes to make improvement. And it gets down to the interprofessional approach to things. It gets down to thinking about culture and the impact on culture that making improvement has.
But I think the good news is specifically to your question, there's been an awakening to this need, and part of it's been forced upon us, but however we got there. So there are very specific things being done, particularly at the resident and fellow level, and it's just at the very beginning. And so part of my new job with quality and safety with the hospital will be to help facilitate some of that, getting them involved in, getting residents involved in teams. Same thing with nursing students and other things. We still have, I think, a little more work to go. Dr. Fishback left with the medical on the medical school side. The nursing school, I think, is farther ahead substantially using this thing called CUSIN. But where it's really getting everyone's attention now. So there's conscious effort to incorporate them into those projects. And then I think we can own more of this too. We do quality improvement in the ICU all the time, but we don't point it out to our learners and say, we're doing a check, this is what we're doing a checklist here. A lot of them may not even know about the checklist, so I think we're doing it. But there's very discrete stuff. And we're also having to put, because of the residency requirements, a base coat of education around that. But the problem is there's a shortage of faculty to help guide projects and do those sorts of things. So we're also trying to work on faculty development to help bring faculty along to help guide residents and students through projects.
I think the project understanding becomes easier if even as early as year one, there's a 4-part series of this is what quality improvement is. This is the definition. This is exactly what you did for us in this last hour. For students to say you're going to face this at some point in your career. So when they get ready to do a project, whether it's their 4th year, element, rotation of the month to help the public that they do or whatever that may be, they've already been exposed to it. And so that's where I would think.
I agree wholeheartedly, and there's work moving towards that with the LSC meeting coming up. But
Right.
Agree wholeheartedly.
Right. Unfortunately, I'm seeing some more hands go up, and this is great discussion, but we're out of time. So what I would like to suggest is we will meet again in a month for the second in this second session in the series about quality improvement. Please turn in your surveys, either leave them on your desk or at the end of the row. We will focus the next hour on talking about quality improvement in education, teaching quality improvement. Thanks very much. It's April 4th.